Bienvenue à la session scientifique du département de médecine familiale du mois de juin 2020. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session.
Welcome everybody online to another virtual session of Research Grand Rounds. My name's Doug Archibald. I'm the Director of Research and Innovation for the Department of Family Medicine, and I'll be today's moderator. And it's my great pleasure today to introduce two esteemed speakers. First will be Judy Belle Brown, and she'll be speaking to us on recommendations for patient-centered telemedicine. And just to tell you a little bit about Judy, she is a professor in the Center for Studies in Family Medicine, the Department of Family Medicine at the Schulich School of Medicine and Dentistry at Western University. And she is also at the School of Social Work at King's University College in London, Ontario. Dr. Brown is the chair of the Master of Clinical Science program and the PhD in Family Medicine at Western. She conducts research in the areas of patient-centered care, interprofessional teamwork and team building, physician well-being, physician practice behavior, and double-duty caregiving. She has presented papers and conducted workshops both nationally and internationally on the patient-centered clinical method. And today she will discuss learnings from patients' experiences with virtual care encounters during the pandemic and provide recommendations for patient-centered telemedicine. So Judy, welcome, and thank you so much for sharing today.
Thank you, Doug, for the introduction, and it's my pleasure to be here. I'm actually I believe the phrase is the pitch hitter for Rochelle Ashcroft, who is currently doing a very intensive week-long teaching session at the University of Toronto. And because she and Simone are actually the two principal investigators on this study. So I'm here to assist. The title that you see on this slide is actually the title or the goal of this grant or of the study. In fact, I do not have recommendations for you today. I wish I did, but we've come here today, and Simone will be helping me with the more thorny questions that you may have later on, to really get your ideas and suggestions to strengthen this research work. But I think what you'll see is, as we move to the next slide, that we have quite an amazing research team. As I said a moment ago, the co-principal investigators are Rochelle Ashcroft and Simone Dahrouge. Rochelle is from the University of Toronto School of Social Work, and you all know Simone. I'm one of the co-investigators, along with Catherine Donnelly, Bridget Ryan. So Catherine is from Queens, Bridget is from Western, Lisa Dolovich is at Toronto. I'm not sure where Jean and David are. I think David actually is a community physician. And then of course we have our very important knowledge users, an essential part of this grant that I'll tell you about in a moment. And we have Kavita Mehta from AFTO, as well as Sandy Gill, Jennifer Rayner from the Alliance for Healthier Communities, and Javid Alou from the OMA. And we have our trusted and very important research assistant, Simon. So if we go to the next slide, you can just see the graphics of our knowledge users who are helping to guide the study, and very critical. This is very important in terms of the funding for this study. You'll see in a few minutes that the funding comes from the Applied Health Research Question funding through the INSPIRE program. And to apply for one of these grants, you need to work very closely with knowledge users, oftentimes health policy makers, and therefore their input is critical in crafting the research question, helping to source out the potential data, and also to interpret the findings at the end of the study, and certainly in terms of knowledge transfer and dissemination. So we're very delighted to have such a tremendous group of knowledge users and to be collaborating with them. And I give full credit to Simone and also to Rochelle for engaging these folks as elegantly as they have. So we all know that COVID-19 has resulted with a rapid shift from in-person appointments to virtual care appointments across primary care. And what was really thought as maybe a possibility 3 months ago suddenly was catapulted into our everyday reality. Yet little is really known about the patient experience with virtual care appointments at this time during COVID-19. I think we've all heard a lot of anecdotal stories of, gee, it's great, I don't have to travel so far, it's just, I have better access, just lots of different comments from patients, or even from our colleagues, or even from ourselves. But I don't think we really know what this means for patients. So given this, this sudden adoption of synchronous virtual care, probably will be sustained. I think we're all saying and predicting that it's really going to change how we deliver primary care. So there really is imperative for us to understand more fully what are patients' expectations as well as their experience with this approach to care. So on the next slide, you can see a definition of virtual care. And I'm sure there are lots of different definitions popping up in the literature now. That with this definition from Digital Health Canada, which came out in November 2019, states is that virtual care represents any interaction, whether it's synchronous or asynchronous in nature, between patients and or members of their circle of care, using any form of communication or information technology. So in our study, we're looking at synchronous virtual care, either telephone and video appointments. And again, as you all know, and I'm sure many of you are experiencing, you've really moved your clinics to telephone or video appointments. And I think that we're hearing more and more that still, I know here in London, at Western, in our teaching centers, that our clinics or teaching units are still almost 90% virtual, and actually 90% of that virtual care is being provided by telephone. Very little video because it's been restricted to through the hospitals just to WebEx. And I think that some folks have tried to use OTN with mixed success. Certainly, prior to COVID-19, the majority of primary healthcare appointments in family health teams, just family health teams we're speaking about, in person and on site, whereas since COVID-19, 75%, or I would suspect perhaps more, in family health teams again are by telephone. And this is very recent work by Catherine Donnelly and colleagues who very quickly got surveys out to the family health teams. And again, speaking to the strong collaboration between AFTO and our research team. So the next slide, the purpose of our study, so this will now really shift to an overview of our study, is to develop recommendations about synchronous virtual primary care for the perspectives of patients based on their experiences during COVID-19. And I think that this will be very interesting in how we can sort of extrapolate this information going forward may be very, very helpful. It's a very quick timeline from May 2020 to March 31, 2021. And again, as I said, the funding is through the Inspire PHC program. The co-principal investigators are Rick Glazier and Michael Green. And this study is funded through the AHRQ, so the Applied Health Research Question Program of Inspire. So the next slide, the thing here that I just want to So we're now kind of getting into the nitty-gritty of this study, and we're looking to you all for your input and ideas. So we are considering exploring 5 dimensions of care from the patient's perspective. So access, their experience of the patient-provider interaction, issues around privacy and confidentiality, and I'll return to that in a moment, whole person care, or what I would call patient-centered care, and also the patient's perceived quality of care that they received in this virtual encounter. If we go back to the privacy and confidentiality, some of the work that Bridget Ryan has done has been really looking at patient portals. And she did do a qualitative study interviewing patients about their perceptions of patient portals. And one of the things that came up for them was certainly privacy and confidentiality for the patients. So, and I think also we actually had a conversation in our departmental meeting yesterday about July 1 is around the corner, and we're all getting our new R1s coming into our teaching centers, and the issue of privacy and confidentiality around virtual visits and what that looks like, and then also the issue around medical students and how much do you engage them in virtual visits. So there's lots of issues to consider. So as we move to the next slide, I'm just going to share with you, this is a concurrent mixed method study. And it's the first portion is really a provincial-wide survey, and this has lots of possibilities for your input, please. We're going to be trying to survey patients who've had at least one synchronous virtual care appointment related to either an emergent issue or a chronic condition such as diabetes, COPD, mental health issues, with a primary care provider. And we're very broad in that definition to be a family physician, nurse practitioner, pharmacist, social worker, etc. And in our survey, which is under development, so again, welcome your input. We really want to target the 5 dimensions that I just highlighted a moment ago, and also potentially using the patient perception of patient-centeredness, so the PPPCR. The R is because it's been revised from its original form, which was developed here at Western, and then underwent more development under the direction, again, of Bridget Ryan and Moira Stewart and myself. And it's a patient-completed questionnaire, 21 items, really looking at the patient's experience during that encounter of their perceived patient-centeredness on the 4 dimensions of patient-centered care. So the next slide, you can see some of our recruitment issues. And again, we welcome your input here. Our thoughts are, and we'll love your input again, is really email recruitment. So to email primary care practices, family health teams, community health centers. We are very fortunate having our knowledge users being from AFTO and also from the Alliance. We're also thinking about emailing patient advocacy groups, the patient advisory committee comprised of members from Ontario Health, and we're certainly seeking additional methods for survey distribution in order to have a broad reach and representation. So the next slide, you can see that we're now shifting to our qualitative individual interviews. So a mixed method study, which is I think the way to go, which you all be going these days. We're going to attempt to have 50 qualitative individual interviews of 30 minutes in length. They will obviously be virtual. Again, it may be some debate about how we actually do those virtual interviews, whether they'll be by telephone, potentially Zoom, WebEx. The idea currently is to recruit these participants, these patient participants, would be self-identified from the provincial-wide survey. And there are some challenges in this approach. And the analysis would be a qualitative content analysis, or really looking for some of the overarching ideas and themes that emerge from the data. So the next slide, I'm turning to the challenges, and we have challenges that we're facing here. We're really, the scope of the project is a challenge. We're striving to include patients from all types of primary care models in Ontario. And also we're looking at what additional methods we can use to recruit individuals who have accessed telephone and video appointments, again, to have a much broader representation of patients across the province. We will be conducting this only in English, so that is a limitation. And I know that you folks at University of Ottawa are very excellent at doing things from a bilingual standpoint, more than some of us in Southern Ontario. And if we go to the next slide, I will thank you. And just open it up now for your input and comments and questions. So, and again, I would like Simone to also step in if there are questions I can't answer fully. Thank you.
Thank you very much, Judy. Can everybody hear me?
Yeah.
Great. Okay, so I'll open the floor now to questions.
Just questions and suggestions on maybe how to reach individuals, because it's easier to reach those who are in the interprofessional practices, like the family health teams and the CHCs, because there's maybe an organization that can help sort of support the dissemination of things to those sites. But how would you suggest we reach the general population to respond to the survey?
Bill Hogg has asked here, can we see the patient perception of patient-centered care survey?
Judy, I think that
I have access to it right now. No, I don't, but I can tell you about it if that's helpful. Is that helpful, Bill?
That'd be great, thanks.
Okay, so it's a 21 item measure that asks, it's on a Likert scale from not at all to completely, roughly, those are the anchors. And it asks, for example, how well did your doctor understand your problem today? How well did to what extent, I'm doing this off the top of my head, to what extent does your doctor, and again, we're talking about physicians, but it can be adapted to all healthcare professionals. So just change it to your provider. So does your provider understand your values? To what extent does your provider understand you as a whole person? So again, it goes through each of the 4 dimensions of the patient-centered clinical method, and this was really the revision to the measure. Previously, the focus was more on the finding common ground, and only one question on understanding the person. So, just as background, the 4 dimensions or 4 components of the patient-centered clinical method are exploring health, disease, and illness. Number 2 is understanding the whole person. Number 3 is finding common ground around management, around the goals and management. And number 4 is enhancing the patient-doctor relationship. And again, this measure is used right after the patient-doctor encounter. So it can be right after, but it can be within a reasonable time frame to have good self-report. And we've used it extensively in studies that we've done here. It's been used in other locations as well. Does that help? Does that clarify, Bill?
Thank you.
Yeah, I have it on my screen. I have it open because I'm on my computer. So if you wanted me to share this, I think it might be helpful because one of the things we are going to have to take into consideration is what are the kind of things that are unlikely to change in during virtual encounters, or in terms of that whole patient-centeredness. Like, if your provider knew you last week, he probably still knows you during COVID, but maybe people feel differently. And what aspects are more likely to change quite a bit given the context?
I think there's another question that popped up in the chat there. And I couldn't see it all, but my the center is one dimension, or 5 dimensions. So just to repeat them again, the dimensions of care that we're interested in are access, the patient-provider exchange, privacy and confidentiality, perceived quality of care, and whole person care. So, which again I would use as the patient-doctor being patient-centered. So certainly we are hearing a lot anecdotally from patients about easy access. I can do it from home. It's much more convenient. But so what are the other issues that patients are experiencing?
There's another question.
There's
Judy,
another question there. Would you like me to read it, Judy, or you want to address? The question is from Prisa Resapar. If the samples will be collected at academic centers, will we be including residents? And are we considering if patients seeing their own physician versus another physician?
Very good question. It's interesting because I don't know how it is at the University of Ottawa, but now at Western, our urban academic centers are all now part of the family health team. So they definitely could be included in the sample. And that would raise the issue of, do you include residents or not? Or are they, and also, if I understood the question, does it have to be one's regular physician or regular care provider? I would probably say yes, but I'll take your comment, Simone.
Yeah, so yeah, we are going to ask whether that's their usual, because what we're going to ask them about, we're going to ground them into their last virtual encounter. So that's to ask specific questions, and we're going to ask if that was with their usual provider or not. And then we're going to ask more broad questions about overall their experience with virtual encounters and how many they've had and their overall perception, to understand whether, the more they have, the more they might be feeling comfortable with things, or, if it's with their provider versus someone else. So yeah. Yeah. So I can see Claire Kendall's comment. I think there's a unique access issue. Yeah, that's important. So we're definitely going to ask questions around convenience, all aspect of access. Actually, if you remember the Levesque framework with essentially the affordability, the appropriateness, the ability to seek. So does it make it easier for you to have an encounter with your provider? So we're going to include questions across all these dimensions. And I guess continuity, we're going to ask about whether they're seeing their own provider or not, unless you're suggesting another measure for continuity, Claire?
No, I don't think so. I'm just reflecting on some of the challenges we're having in our contacts, and they may be quite different from setting to setting, right? Like for us at Briere, we're based within a hospital that's had unique impacts on our ability to see our patients. And we're both, I think, better and worse in other settings. I'm not quite sure how to capture that. I know you'd be looking by model, but partly being an academic, I see Priest had a comment about the academic setting, and as well as, maybe being hospital-based and dependent on the hospital for PPE. But I'm just really mindful that some people are quite happy to have their care virtually, and some are really struggling with it, you know, pleading really to be seen and having to be told no.
Yeah, the thing that I wonder about too is that, you know, the sort of that first blush of something new and exciting that was really great in March and April, when everyone's anxiety about COVID-19 was fairly high. But now as things are, you know, opening up again and people are seeking to go back to their normal, whatever that is, you know, are they going to say, "Oh, I really want to see my doctor now. I don't want to do virtual visits anymore if I don't have to." And there, and as you say, I think there's a very good point about, you know, patients may have been more at ease going into a clinic, whether it was academic or not, in the community versus having to go into a clinic in the hospital, which I think just had more fear around it in terms of, you know, what was the potential of getting the COVID, as they tell folks.
We have another question, Judy. This one's from Eileen about what about the elderly who are not tech savvy, disadvantaged folks, either they're deaf, mentally challenged, etc. Seems to work well for the young and able-bodied. And I think this gets back to Scott's question too about like the technology assessment, acceptance model and so on. I'm wondering if you could speak to that, and then feel free to jump in, Scott, in your question as well, or Eileen as well.
I think you raise very good points. I think what's interesting though is that because of the technology issue, that what I think we're understanding to date is that the majority of the visits have been by telephone. That people have not been using OTN, have not been using WebEx, have not been using Zoom or whatever other sort of video conferencing platforms. And I think partially because of the issue around people, you know, the elderly not being tech savvy, not owning a computer or a smartphone. So I think that is one of the challenges. But what does it mean going forward? I mean, one of the things that we heard, I believe somewhere in the news about, you know, maybe this really pushes us now to address the bandwidth issue, the internet issue in rural and remote areas in this province, in this country. So I mean, I think it's got the whole digital thing is another spin-off. Sorry, I'm deviating from the point.
No, but this is it's very relevant, I think, for sure. Go ahead.
Yeah. So I mean, I think it's interesting to see where this is going to take us as rapidly as it is, in ways that maybe we never anticipated because of the pandemic.
I'm seeing a lot of, you know, really pertinent questions, you know, in terms of the, you know, the marginalized populations, the effect changing over time, the ability or inability to engage family members when you're on a telephone. And so this makes me think about the statement you made, Judy, about the scope of the study. What are we, you know, what is a reasonable question we're able to answer? And we're already struggling because our stakeholders want to have a broad set of information, including patients' experience in the management of chronic conditions, mental health, other chronic conditions, as well as in more acute or emergent conditions. And, you know, I think that the factors that, are different, you know, les enjeux, the things that, the benefit of virtual care would be quite different in the two conditions. So I think there is just so, you know, and then depending on the population and depending on when. And so I think there's such complexity that we're going to have to say, this is what we're able to do, and just sort of accept that we will not be able to go beyond, because this is a 10-month study with a very limited budget. And it just speaks to the complexity of the issue.
Yeah, absolutely, Simone. And I think that I really want to highlight not only the short timeline, but the teeny little budget. These art grants are not big budgets. So it's being creative on a shoestring.
Yeah.
But I think we believe enough in the issue, in the topic, in the question, that we're prepared to do that. But I think what I'm hearing from folks is that, and I really love your ideas and questions, is we need to perhaps narrow our scope in order to make it meaningful. Otherwise, we're going to have a lot of little pieces that are not coherent, and that's concerning to me.
Thank you. Cleo, do you have any further comments?
Well, I was just putting in the chat. I mean, I was just, listening to Vera Etches, the public health officer of Ottawa, saying on the news yesterday that, in racialized communities, 66% of them have COVID, whereas I can't remember the position, but basically the double incidence of COVID. And so I think, and we just did a very little study, but with an app, but it was very hard to get, these, in our clinics we have at Briere and Primrose, lower SES, refugees, but they don't have time to do an interview. They don't have time to do a survey. But I think if maybe you go to the patient, their advocacy groups, they will find people for you, and I think they will want those people to be able to have a voice in the study. So I think I just know from our experience, it was very hard to get them. So maybe at the outset, finding ways to include their voices would be really great.
And we are working with the community health centers. So we're working with Jennifer Rayner, and she has offered to help vehiculate this in their organization. But they'll still have the barriers you're talking about, Cleo, will patients be able to engage in the survey? They're also doing their own study, but it's about the care provider experience. The challenge is that all the stakeholders, whether the CHC and the work that they're doing, AFTO, the OMA, they're all interested in the global question, right? So whereas when we do studies, if we want to be able to answer something, we have to be quite focused. But our stakeholders are really expressing the need to have a broad lens put on this, because they want this to inform. They're all keen on maintaining some level of virtual encounters, and they want this to inform how they move forward. So it's a challenge.
From another sort of standpoint, it highlights the challenge of working with knowledge users and stakeholders who are not research savvy. And now I say that, and Jen Rayner is very research savvy. So Jen knows this, but I think also Jen gets pressure from the organization.
Yeah,
we want this information. So it's just one of the, I think, the challenges of the dances that we as researchers have to become very skilled at, in terms of how do you collaborate in a way that reflects the reality of what we can actually do, and do it well, because you don't want to do a half-baked job in terms of your research. So it's that very fine balance.
So Sarah's mentioning her interest in understanding the northern communities or the rural communities. Again, this is about our ability to reach the sort of the breadth of the population, or the different segments of the population. And so if folks have any ideas, and so actually Sarah's saying that they're mostly served by FITS, that might make it a little easier, but FOEs, it does not necessarily make it easier because there's no sort of organizational structure through which we can operate. But any ideas or any volunteering to, move the survey in your area, in your context. The other thing is, so maybe before, I think we might have another minute. What do people think that in your practices, if we were to engage practices and say, listen, if you give this survey to your patients, we might have enough of a sample size to report back to you. And so that could be an incentive for them to participate. And by participate, I mean sending the survey to their patients. We just don't want them to cherry pick. Does that sound like a reasonable way to reach patients, to increase our reach?
Bree says, noted, my concerns also that patients who are already well served because of their socioeconomic status will be even better served, leaving little time for you to reach out to marginalized patients. Teresa, if you want to speak to that, by all means.
No, I mean, that's what I meant, right? And even in our sample size in Clio, expressed that quite eloquently, right? Is that they're very savvy. I mean, in my experience, all my Persian-speaking patients who are already extremely isolated, I just actually got a phone call, run over by a car and can't communicate with anybody on the phone except with me. And right, so I think these are the patients that will not be included in your survey one way or another, even if you are in the community health center. So I think, and so then the perception you get is from those people who are already very well served. And I worry that their perception of patient-centeredness might be also different because they expect very different different way of being served versus the ones who are extremely marginalized, and any care they perceive as a privilege. Yet the ones who are very privileged and overserved tend to not ever be satisfied with the care that they're receiving. I see Cleo smiling. So, right, Cleo? Yeah. So I worry about that perception. Quite a bit. Yeah.
Judy, do you have an idea? The only thing that I can think of is to make sure that we capture the individual's social context and that we report on things separately. Right? I think
like
from
their
everything you're saying,
their postal code.
That's right. That could, even if they don't answer questions about it, just their postal code could help. So that would be one way of at least not introducing bias or minimizing bias.
The thing about, and I'm just speaking solely to the measure of the patient's perception of care, that it is, it's not asking about satisfaction. So it's not a satisfaction measure. I want to be very clear about that. It's really asking about the patient's perception around dimensions or aspects of that encounter where they felt as if the physician understood their illness experience, understood them as a person, found common ground around what the management plan was, and also the patient physician or patient provider relationship. Did they feel they trusted their doctor, etc. We've used it in fairly broad samples, and I don't think we've seen a socioeconomic variation in that. So again, I just want to emphasize that it's not a satisfaction measure. That's a key point. But that being said, I'm not totally agree that I think there is a population that we will not capture for many reasons. And I think that if we had a lot more time and money, we would be able to do that. And maybe what this is just the springboard to a big CIHR grant that may be pan-Canadian. But the one thing that I will end on and just brag about briefly is that I'm delighted to say that 4 of the individuals who are on this grant, Catherine, Bridget, and our principal investigators, Simone and Rochelle, are all tutor alumni. And I think, and they were not on the same cohort, but I think it speaks to the strength of tutor and the mentoring that comes from that goes on and on and on. It doesn't just end in when they attend tutor, and it's that really pan-Canadian collaborations that exist. Yeah. So I'm just thrilled, and I'm thrilled that they've invited me to be part of this grant, and it's just marvelous to see the energy and the dynamic stuff that comes out of these collaborations that are not can't totally attribute them to tutor, but I think that tutor has played a role in providing that.
Absolutely.
I'd now like to introduce our second speaker this morning. This is our own Dr. Simone Dahrouge. She's an associate professor with the Department of Family Medicine and a senior scientist at the Briere Research Institute and also ICES. She's director of our regional practice-based learning network, the Ottawa Practice Enhancement Network, or OPEN. And this network is a learning collaborative comprised of primary care practices focused on enhancing primary care in the Ottawa region. In 2014, with funds from the CIHR CBPHC team competition, she established an innovative navigation model, the Access to Resources in the Community, or ARC model. This was funded through the CIHR SPORE Impact Grant and the provincial HSRF, and now through the Ministry of Health. Today, she'll tell us about how this navigation model will be applied to support individuals access resources that addresses COVID-related needs. So on to you, Simone.
Okay, terrific, thank you. Thanks, Maddie. Okay, next slide. I have no conflict of interest. I don't make money out of anything that's I'm sharing with you today. Next. This is a list of the team. There's a lot of knowledge users, patient care providers, decision makers, as well as researchers with various backgrounds. So I think we've got a wonderful team working on this, and statistician, economist, and social worker, and so on. Next. Okay. So in 2014, funded by the first CIHR SPORE competition, actually, which was the CBPHC, we asked our region what was their priority in access to primary healthcare. Where were the biggest problems they encountered? And they said that there's lots of resources in the community that are available to help people achieve health and well-being, but that these were not being used because patients or individuals experienced barriers to accessing these. And as a result, there's unmet needs, and the situation increases the inequities across groups, so across social strata, because the individual's social context contribute to the barriers and makes them less able to access the resource. Next. Okay, so then we undertook consultations so what were we going to do about this? So we spoke to primary care providers, we spoke to patients to understand could see how we might be able to address them. So the doctors told us, well, these services are forever changing, and it's not possible for me to keep up to date on it. And those of you who might remember the Blue Book, so that's essentially, that Blue Book had the list of resources, but these things kept changing, and now there's so many, you really can't be on top of it. And even if they did know they have limited time in helping the patient, they can make a recommendation to access a resource, but they have limited time to help them navigate the system and get the one that's best suited for them and help them overcome barriers. The patient told us, well, we don't even know what's out there. We don't know what we're eligible for. A lot of individuals said, you know, with limited literacy, health literacy, confidence, they don't have the awareness, and they don't about the services, and they don't know how to navigate the system. And again, even if they were told about a resource, they have barriers that that would prevent them from accessing it. So they need support to help them access the resources for them. So what we decided to do is, we undertook a search of the literature to identify what was the best strategy. It turns out, you know, patient navigation should be able to help patients overcome barriers, and if we attach it to primary care practices, then we can help the providers that would then be asked to identify patients in need, and we would help the individual access the resources that they needed. So lots of navigation services out there, and this slide is just to demonstrate that the ARC is distinct from the other existing navigation services. One is that it doesn't target a specific population. Most navigation services do. You can think about, you know, those for either new immigrants or those for mental health patients, or and so on, or those for medically complex patients. The services next, so we are distinct in that we are a generalist service, and that is not, thank you, that is not focused on any medical issue. So what are the ARC principles, or what are the facets of the ARC navigation? So it's a lay individual, that's really important, bilingual, and helps the individuals access, you know, health and social services or programs that can help them achieve their goals for health and well-being. It's a generalist, like I said, not targeting a specific population. It addresses whole person need, or it's patient-centered, in that, you know, if a patient comes with a referral to ARC with their doctor having said, well, you know, their diabetes is not well managed, I'm sure there's stuff out there, we can help them determine, you know, what's best suited for them. Do they want to begin with maybe some diabetes education, maybe with a healthy lifestyle? Which approach? Is it exercise? Is it diet? And maybe through these encounters, they tell us that, well, you know, they're depressed and they really are not motivated. So then we can help link them to the appropriate resource. So it's really a whole person care. And again, just focused on non-medical needs. The navigator is attached to primary care practices, so that helps improve the continuity of information. It's the primary care provider then becomes a resource to the navigator who's not medical, doesn't have a medical background. So if they encounter problems, like there was, you know, one patient who was suicidal, we can link them right away back to their provider. So, you know, it's really good to be embedded in that sector that really oversees the patient care. And at the time when we started, we were linked to a community health center because we thought that, well, at least the ED of the center we were working with felt that this could be the kind of thing that his center could adopt. And he saw that broad navigation as part of the role of the CHCs. Next, I should mention that, you know, the CHCs serve a very complex patient population, and these services are, that kind of support is essential. The target population of the ARC program is that, you know, consider the working poor. So those folks who are not so disenfranchised that they, you know, maybe homeless, or, you know, maybe just don't have any resources around them. They're functioning, but they're going to get sick because they don't have the appropriate support to reach the services that they need. And some estimate that to be about 40% of the population who lack the sufficient support or have barriers that they can't overcome. So what did the ARC model look like? So you see primary care identifies the need in the patient. You see that first arrow then sends it to the patient navigation activities or intervention. As I said, the navigator helps patient prioritize and understand their barriers, helps them overcome their barriers, builds confidence, helps them build self-efficacy by showing them how to navigate the system, but ultimately does help link them to, you can see the arrow then ends with the community resources that best suit them. And there's that, integration across the sector. And that's the role of the navigator to maintain the information flowing between the two sectors. So that's the model that we have been working with. Next. I'm going to skip this because this essentially was just to demonstrate the referral process. So essentially what it was intended to show is the doctor with the patient. It's intended to be, again, quite very patient-centric, and it's a co-decision. So with the patient, it identifies the needs that they want to address, because if the patient's not involved in that decision, they're much less likely to be engaged. On the flip side, I think the patient is much more likely to be engaged when the provider discusses that with them, when they help the patient identify it and make the recommendation, as opposed to just the patient on their own saying, yeah, I should really lose weight, but when the provider actively makes the recommendation, I think it makes a big difference for the patient. So that's what this is intended to show. So we conducted a feasibility study and a randomized control trial looking at this type of navigation in the general population, so in primary care practices. The randomized control trial compared the sort of in-person, or part of the encounters were in person, mostly the first one. So that kind of the ARC navigation to the provincial navigation web and telephone service, which is called 211. If you guys don't know about 211, I'm happy to help orient you. I think it's a great service that we should all be aware of. So what type of needs did the patient who come to us have? So often they had multiple needs, sometimes up to 7. So 23% of all the needs related to mental health and addiction. 72% of patients had a history of mood and anxiety disorders, and more than half had a mental health need that they wanted to address. So although those needs represent a quarter of the needs, more than half the patient had such a need. Next. Okay, I'm going to skip the trial. This is just showing you the participation. Essentially, there's the intervention. The individuals were randomized to the ARC navigation services or randomized to 211. If they were randomized to 211, we just told them about the service, gave them the information, told them how to contact them, and that was the end of our contact with the patient. They were randomized to the ARC navigation. We then proceeded to make an appointment with the ARC navigator. I just want to mention that virtually everybody, like the vast majority of patients who are randomized to ARC, made use of the services, but less than half of those who were sent to 211 actually contacted the service. And that's based on what they told us 3 months down the road when we did the evaluation. We lost some patients to follow up as expected, a little more in the 211 arm. Next. Okay. So our main outcome of interest was whether the patient reached reached a service that they had identified as addressing a need. So in the ARC arm, patient accessing, something looks funny to me here. Oh no, that's fine. So in the ARC arm, 46% of patients accessed at least one resource versus 31% of patients in the 211 arm. This is an intent to treat analysis. So for those of you who are not really familiar with this, those patients that we couldn't contact, we lost some, maybe about a quarter lost them to follow up. The sort of standard approach is to assign them a 0, a negative outcome. So we treat them as if they hadn't accessed the service. And that can cause some potential biases. If we only include those patients who responded, we still see that ARC is better than 211, but maybe the gap isn't as big. But essentially, patients benefit by about 45% increase in access to resources if they were randomized to the ARC arm versus the 211 arm. Next, the other way to look at it is that the patients, because remember I told you that each patient had multiple needs. On average, I think it was like 2 point something. So did they access more resources? So again, if we do the intent to treat analysis, on average, an individual accessed 0.92 resource in the ARC arm. So that means that could be something like, one patient accessed 2 resources and another patient didn't access any. That would be an average of 1 resource per patient. Whereas the numbers were about 2/3 of that for the 211. The gap is considerable. It's 36% relative risk, but this is not statistically significant. Next, and now I think that part of the challenge, you can see that I showed you that most patients didn't actually access 211, and I think that with the provider making the recommendation, which is not usual care in terms of printing a referral form, talking about the navigation and giving them information, that probably increased the individual's engagement in their self-care. And we know that that happens the more the provider is engaged. So we know that providers make the recommendation, but not necessarily to specific needs, and they don't usually write a referral the way they do for specialty care. So the other thing that we observed with ARC versus 211 is that there's a possibility that ARC can mitigate the effect of the patient's social context on access. So if you look at 211, those patients who did not have university degree and were assigned to 211, 31% of them accessed a resource, compared to nearly double for those who had a university degree. So 57% versus 31. In ARC, the gap is shrunk. Those with less education were slightly less likely to access a resource than those with the university degree. So that's encouraging. Next, we didn't see this reduction in gap across all the indicators. So in this case, it's those folks who are Francophone and are considered more disenfranchised. ARC was able to increase access to resources compared to 211, but in the same amount for French and for English. And in this case, actually, this slide actually shows the Francophone population having better access than the English. So kind of maybe makes you question the whole notion about the imbalances across the two groups. Next. Patient experience, hands down, no comparison. Obviously, the ARC Navigator applies a very patient-centered approach, and it's really valued by patients. So these are the proportion of patients who said yes, yes, generally, or yes, definitely. So that's quite good. That's in blue compared to the 211 patients in red. Next. Okay, so what do we know and where do we go from here? So first is that, and there's lots of clicks, maybe you could do 3 clicks, Maddie. So we know that the ARC Navigator can help individuals overcome their barriers. We know that they can help the individual access resources better than without that kind of support. We imagine, but we don't have strong evidence that this is going to improve the individual's sense of sort of maybe well-being, and we haven't really looked at it. And we think that it's closing the gap across social groups, but we still don't have strong evidence around it. Next. But what we don't know is really what is the impact of patients accessing these services, so these health and social services. Does it really reduce their needs? Does it have an impact on health service utilization? And ultimately, does it have an impact on their health? Next. So the pandemic-related needs. If you consider the needs that we are anticipated or that we know exist in the pandemic context, we know that mental health and addiction is a huge priority. Finance is another very large priority. People have lost their jobs. People have felt socially isolated. And there's a higher consumption of substances. Parenting made up 6% of the needs before. We think that there's probably going to be more family and other social types of needs during the pandemic. Physical, so healthy lifestyle, physical activity, healthy eating, that's also should be part of the priority, although it may not always be evident. That's going to be something that we should help patients address during the pandemic. Next. So the Ministry of Health said to us, we now want you to give a small amount of money. We now want you to go and in communities and help address COVID-related needs. So what do we have to change in our ARC model to be able to do this? One is we're going to have to do virtual encounters. And I'm sure that some of the benefits from ARC came from that relationship that was built with the individual, because in 70% of cases, the first encounter was face-to-face. And the other 30%, it's just that the patient didn't feel they needed a face-to-face encounter, so it was virtual. We're going to keep it generalist, although we're writing a grant now to apply it for individuals with mood and anxiety disorders, because the grant is focused on that, and that's been a big part of the population we've helped. We're still going to link it to family practices, but we know that family practices, at least in the near future, are not going to be operating the way they were operating at the time when we did the initial studies. They're probably going to be focused on catching up on some of the procedures that they couldn't do during COVID, like cancer screening. So how much ability, how much capacity is the primary care provider going to have to be able to address these, to identify needs in their patients? Health needs, I think, medical needs, I think that'll be part of the journey. But those sort of less tangible or maybe the type of needs that don't necessarily, that are not necessarily regularly part of an encounter that really need to be elicited, they may not have the capacity to identify those. So we want to reach individuals beyond the primary care. So we're going to go in regions, and we're going to do, rather than doing a practice-based intervention, which is essentially what we did, practice wanted to participate, we'd say, you have the navigator available to you. We're going to go in small regions, and we're going to disseminate the information about the availability of the navigator across that region. We're going to engage community organization to help us vehiculate that message. We're still going to want the primary care providers to engage, because we want that anchor. We want the patient to have a home that we could go to help them, to help connect back, to keep somebody up to date on what's happening with their patient. So that's an important element for the continuity and coordination of patient care. But probably the primary care setting is not going to be sufficient for the identification and recruitment, which is why we're now going to be linked to community organizations to help us promote the study, or promote the service. Next. Okay, so what are the sort of the facets of the implementation? So one, we have to do a rapid implementation, like all the COVID-related initiatives. We've got to get out there really quickly. We want it to be pragmatic. So maybe those of you who don't know that term, a pragmatic research is a research approach where, for the most part, it doesn't look like it's research. So we don't ask the patient to complete, a 40-minute survey. We don't have multiple contacts with the patient. It should look as much as a regular program as you can, without compromising ethical considerations and some need for data, but we're not going to be doing questionnaires. And these are the pandemic related needs that we are anticipating, but we're not going to be limited to that. So whatever need the patient has in this context is what we're going to address. Next. Okay, so because we're making a lot of changes to how ARC is being delivered, we're going to do a pilot study. We can't roll it out large, and also we don't have the money to roll it out large. So we're going to do a cluster randomized trial. The cluster is going to be a region. I'll show you a map in just a second. And so when a region is identified for the intervention, we're not going to take the neighboring regions for the control site. We'll go somewhere else. Same engagement, as I said before, primary care practices, community organizations, and our outcome measures. We really are not sure what actual impact this is going to have. What should we be expecting? Next, I think in general, you can say that if you address people's needs, the more people have unmet needs, the more likely they are to have, encounters with the emergency room utilization, or maybe end up in hospital. So that's true, but if the needs are more health and social and not medical, because the consequences of unmet medical needs are more immediate, but not necessarily for health and social needs. So will we be able to see something? I mean, I'd love to hear your feedback on this. This is our sampling frame. So this is the sampling area, and we broke it into region for sampling. And we've already sampled, gotten our intervention and control communities. Next. And these are that's the evaluation we're going to undertake. We're going to analyze the navigator log, and we're going to go into health administrative data because we're minimizing primary data collection. We're going to have to rely on health service encounters and maybe inappropriate use of ER and hospitalization as our outcome measures. So it's a pilot. We're not postulating that something is going to happen. I mean, we're not postulating an effect size, but we are hoping that what we're going to see is a reduction in maybe the number of visits to the primary care provider. Somebody had suggested that that's what happens when you help, the literature suggests that that's what happens when you help address mental health needs. Maybe eventually reduction in ER and hospitalization. Next, I think that's it. Yeah, and these are our partners, our collaborators, and our funding partners at the bottom.
Simone,
okay.
Thank you very much.
Yeah, so thank you. So Bill is asking, how do we select, train, and support the lay navigator? That's a really good question. So first, we have just a wonderful patient navigator on the team right now, and that's Natasha. If you want to put your camera on, Natasha. So we selected Natasha based on her communication skills, on her interpersonal approach. How did we train her? Well, Daireen, if you're able to put your camera on, don't be shy, guys. Daireen developed a full curriculum. This is like 4 years ago, right? Before there were some schools who trained folks on navigation. So she developed a full curriculum, which is part online, part face-to-face. And we've actually helped train navigators for the CHCs, navigator on the social accountability initiative. Claire, you'd be interested in finding out. They were part of the training that we delivered to our navigator. Yes, we pay them. They're lay. They're not necessarily, what we call peers that you sometimes don't pay. Yes, we pay them. And in fact, the ministry was really insistent that we pay them for better retention. So if we look at different spoken languages, so that's an important thing. We wanted to make sure. Now remember that we are not targeting sort of the most disenfranchised, those who are alone and can't communicate, and those for whom the CHCs are really the best place. But we do want to respond to the general Ontarian population, including those who don't speak the two main languages. So we did have access to translation services, and I think we made use of these very rarely. What we did is, if somebody had language barriers, we engaged a family member. They always had a family member that could work with us to help the individual. We also included children. So we worked, so it was a child's need, but the parent was the person that we worked with to help address the child's need. And I can think of somebody with, I think it was ADD or ADHD, and really having difficulty. The family was having difficulty at home because of the child's behavior, and Natasha was able to find some services specifically geared to those children to, help focus their energy and release the energy. And then, so I think there were, we try to reach the breadth of the population. And you can see actually the Natasha and Daireen have both put their cameras on. Yeah, I'm excited about this next phase, but I worry about, so we've demonstrated, there's no question that we can help, that people love it. Doctors and patients love it, that we can help them link to community resources. But then what impact does it have? And other studies that have done things like, say, diabetes management, it's clear what they're going to look for. Or if they did social isolation, they might do a survey on, sense of connectedness. But because we are so broad, what is the overall impact of supporting these patients going to be? We can't go select one indicator. I love Lois's comment, though. I'll take note of that.
Yeah.
Actually, but let me go back, because I just there was Cleo. What is the publicity? Yeah, we haven't done that yet. So, we do have a flyer, essentially, because we had to get that approved by ethics. It's currently under ethics review. So it's essentially, I'm happy to share it. It's essentially something that says, COVID has, with like half the page being pictures, COVID has caused disruption in our lives. Some people, there's lots of things that can help people, but a lot of folks are going to have difficulty getting to those because they won't know about it. They won't know how to access that service. I mean, I find all these services that the government made available, it's complex. A lot of people, I don't know, are you all aware, for example, that we can have a break on our insurance? And maybe most of you do, but it's not, I think even us, we don't know everything that's available. So I can't imagine those who live with barriers. I assume your baseline data had women versus men in these services. I think it's important to look at domestic. Yeah. need impacting on, yeah. So I think that, you know, the issue of domestic violence is a sensitive one, because I think because the individual who deals with these families or with these women and children has to just, you know, get it right. And there's folks who really know how to do that well. So we're connected to these services. So our role is going to be to really help get that individual quickly to those services. We're also going to loop in the family physician, because that's an important one that the family physician needs to be made aware of immediately. But yeah, I think we can expect that we'll be seeing some of these. Yeah, I think, are you identifying patients who do not have family doctor? Yeah, food banks, that's a great idea. So any of these organizations that are in the region where we're going to be, and by chance, Merrickville was selected as one of our intervention regions. So we'll have to do a few trips there. But it'll be interesting to see what's out there. But yeah, the intent is to partner with these organizations to help them, to help promote the service. We will definitely still take on patients who don't have a family doctor, because there's no point penalizing them twice. But we're going to have to be very careful, because we won't have that backup that I kept referring to. That, you know, we want to make sure that the patient, the continuity of information, if anything comes up, that there's somebody, you know, in their corner that we can, you know, some help we can harness. So I don't know, maybe we can try linking them. We'll make sure they're on the list for getting a family physician.
Simone, I had a question regarding the pragmatic approach.
Yes.
I'm familiar with pragmatism as a philosophy.
That's right.
You know, essentially doing research, I guess, you know, what works. And this is what you're doing. I've seen it associated with fixed methods, as sort of a grounding philosophy for this.
Yeah, so if you're doing studies, they fall into two categories, but in reality, it's a continuum. One end of the continuum is called explanatory trials. And in explanatory trials, you're really trying to answer that question exactly as you've asked it. You're trying to control everything, and you're trying to be able to really explain why you have achieved your outcome. So these are called explanatory trials. In pragmatic trials, you want it to be, because you know how we often say, oh, that worked in the clinical trials, but when we tried to roll it out as a program, it didn't work. Because in reality, so pragmatically speaking, there's lots of things that come into consideration that we actually control during studies that are not controlled in the program delivery. So pragmatic trial are intended to look as similar to a normal program as possible, so that your conclusions are much closer to reality. Yeah.
Thank you.
Oh, increase their income. Cleo, that's a good one. The only thing is, okay, so you're speaking to having to ask some questions to the patients. We were hoping to get away with health administrative data only, but maybe that will not be enough, because we don't have a lot of funds, but to ask them questions, but maybe we could ask a few. So yeah, income, their sense of income security, that would be.